Hey guys, so we're going to go through the adrenal glands today. So we'll start with the anatomy. So going from outside to inside, we have the adrenal capsule, then we have the cortex, and we have the medulla. So the cortex contains three layers. So zona glomerulosa, fasciculata, and reticularis. So you just remember it as GFR, and it goes from outside to inside. So in terms of what hormones each layer produces, we'll start with glomerulosa, so the furthest outside, that produces aldosterone, which is a mineralocorticoid. Then we go to zona fasciculata, which produces cortisol, which is a glucocorticoid. And you'll notice that zona fasciculata is the biggest layer, and that's because the adrenal cortex produces most cortisol. And then we have zona reticularis, which produces your androgens, so your sex steroids. The medulla is where your catecholamines are produced and stored, so adrenaline and noradrenaline. So the way you can remember the hormones is GFR is salt, sugar, sex. So it's getting sweeter as you go closer to the middle. So aldosterone is a salt, cortisol is a sugar, and androgens are your sex steroids. Your medulla contains chromaffin cells. So this is where your catecholamines are stored. It's about 80% adrenaline and 20% noradrenaline. And this is what the feedback loop looks like. So we basically start at the hypothalamus, which produces CRH, which increases the production of ACTH by the anterior pituitary, which then basically increases the production of all adrenal gland hormones. So all your aldosterone, cortisol, androgens, and your catecholamines, and all of those go to your target cells. What's important is cortisol is the one hormone that does the feedback loop. So the hypothalamus and the anterior pituitary are sensitive to the levels of cortisol. So when you have high amounts of cortisol in your blood, hypothalamus and the anterior pituitary will decrease the secretion of CRH and ACTH. The other adrenal hormones don't make a difference. It's just cortisol that does the feedback loop. So all the adrenal cortex hormones are steroid hormones, which means they all come from cholesterol and have these really long pathways. You don't really need to remember what the pathways are, and they'll be more important when we go through one of the conditions later on. Okay, looking at aldosterone. You should have covered this in renal, but basically it's involved in the RAS system. So aldosterone acts on the collecting duct and distal convoluted tubule in the kidney on the principal cells. So it enhances this sodium potassium ATPase pump to increase sodium and water reabsorption and to increase potassium secretion. So overall, that basically increases blood volume and blood pressure. Cortisol travels bound to CBG, which is a cortisol binding hormone. That's because it's a sex steroid. That's because it comes from cholesterol. And it has a circulating half-life of 70 minutes. And the activation of cortisol mainly occurs in the liver. So cortisol has four main areas of action. And the way you think about cortisol is because it's a stress hormone, you think about what happens when you're stressed. So when you're stressed, you need a lot of energy. So that's why in your metabolic section, you're increasing your plasma glucose and breaking down all your triglycerides and your proteins. For your immune system, we suppress our immune system a little bit to ensure it doesn't overreact to anything minor. So basically, metabolic things are increased, immune systems decreased. Cardiovascular, it helps the response of catecholamines. So it basically just supports that. And anything non-essential in our bodies, so like reproductive and our growth axes, we don't need them if we're in a stressful situation. They're more just long-term things. So we downregulate both of those so that we're not wasting our useful energy on that. There are three stages of stress. The first is the alarm stage, which your catecholamines are involved in. Second is resistance, which is cortisol, and exhaustion is last. And you have both catecholamines and cortisol. You don't need to worry too much about what the actual stages are. They never really asked us. But the important thing to remember is catecholamines are your short-term stress response, and cortisol is your long-term stress response. So you would have done a lot of this before. So all the cortisol ones is what we've mentioned before. Your catecholamine actions is what you would have studied last year. So increased heart rate, blood pressure, increased gluconeogenesis, dilation of the bronchioles, increased metabolic rate, and decreased all your non-essential functions. Okay, so on to the conditions now. We'll start with Cushing's syndrome. So what is Cushing's? Cushing's is when you have excess cortisol. There's two categories for this. So you have this thing called primary Cushing's or Cushing's disease, which is when you have a pituitary tumor which produces ACTH. Because if you have high ACTH, that will lead to high cortisol. The other thing we have is Cushing's syndrome, which is when you're just experiencing the symptoms of excess cortisol. So syndromes like the generic one and primary Cushing's or Cushing's disease is that very specific condition where you have a pituitary tumor. So in terms of clinical features, you end up with a moon face, buffalo hump, weight gain, skin pigmentation, high blood pressure, hair growth, thin skin, easy bruising, depression, and osteoporosis. There's some of the clinical features. Cushing's is very buzzwordy, so moon phase and buffalo hump and like weight gain or central adiposity, those are things that come up quite a bit, so it's good to remember them. And this is a picture which can help you remember the symptoms. So in terms of investigations, it makes sense that we'd measure cortisol and ACTH. Now we have this thing called the dexamethasone test. So we'll go through that in a second. So another important thing to note is that if you're giving somebody steroids and you want to stop it, you need to slowly reduce the dose and wean them off it. Because if you suddenly stop steroid medication, your body is like, oh no, we used to have so much glucocorticoids and now we don't have any. So it will start producing a lot of cortisol to make up for it. That's why you need to wean them off it slowly because you don't want that high level of glucocorticoids in their bloodstream. Okay, so onto the dexamethasone test. So dexamethasone is a synthetic glucocorticoid, so it's like a cortisol fill-in. And basically the aim of it is we're trying to give dexamethasone to see how it affects the feedback loop. So what we do is we first test the ACTH and cortisol levels in the patient, and then we give them a low dose of dexamethasone and retest the ACTH. Then we give them a high dose and retest their ACTH. So what we're trying to see is how the ACTH levels change after you give the dexamethasone compared to originally. So we basically describe it as suppressed or not suppressed. So if it's the same as before or if it's lower than before. Okay, so we'll start with looking at a normal patient. So this is part of the feedback loop that we were looking at before. So in a normal patient without the dexamethasone, you have the anterior pituitary that's producing your ACTH. That goes to adrenal cortex to produce cortisol, which goes to your target cells, and also does the negative feedback loop. So if you have high levels of cortisol, that will decrease the levels of ACTH. After you give dexamethasone, you have extra glucocorticoid in your bloodstream. So that means you now have really high levels of glucocorticoid. Doesn't matter if it's low dose or high dose, by the way, but you have really high levels of glucocorticoids. So your anterior pituitary will produce way less ACTH. So basically, giving dexamethasone suppresses your anterior pituitary. That's why we end up with this. So before you give dexamethasone, they have the normal amount of ACTH, normal cortisol, but after you give dexamethasone, your ACTH is suppressed because the negative feedback loop is working properly. Okay, now we'll look at Cushing's disease. So this is when you have a pituitary tumor producing extra ACTH. So that's why I added this box over here. So your tumor is producing a lot of ACTH, which is increasing the secretion of cortisol. But your cortisol is only acting on the normal cells in the anterior pituitary producing the ACTH. So there's still going to be a very high level of ACTH from both sources and a very high level of cortisol. When you give low dose dexamethasone, what happens is you giving a little bit more glucocorticoids, but not enough. So it helps suppress the normal cells in the anterior pituitary, but that was already happening before. And so your ACTH levels are not going to be changed from without the dexamethasone. So they're going to be not suppressed because the tumor is still producing those really high levels of ACTH, and the anterior pituitary was already suppressed before the dexamethasone. The change happens when you give a high dose of dexamethasone. A high dose is just enough to tip the scales, and now the tumor is being suppressed as well. So now both the tumor and the anterior pituitary are suppressed, and you'll end up with suppressed levels of ACTH overall. So originally you'll have high ACTH, high cortisol. After low dose, that's not enough to suppress the ACTH, but a high dose is. This is the reason why we do the low dose and the high dose, because it differentiates the pituitary tumor. Because for all the other categories, there's no difference whether you give low or high. The pituitary tumor is the only time it makes a difference. Okay, so we're going to split syndrome up into two groups. So the first group is an ectopic ACTH producing tumor. So ectopic just means elsewhere, so not in the pituitary. So that's a high ACTH producing source. So we're going to end up with high cortisol. But the thing is, the cortisol feedback loop only works on the anterior pituitary. So while it's suppressing the anterior pituitary, the tumor is just going to happily keep on producing ACTH. So you'll still have high levels of ACTH. After you give the dexamethasone, the glucocorticoid level is really high, so your anterior pituitary is still going to be suppressed. But once again, the tumor is not in the anterior pituitary, so there's no chance of it being suppressed because there's no feedback loop to it. So it doesn't matter if you give dexamethasone or not, your ACTH is still going to be really high afterwards. That's why you have high ACTH, high cortisol, and not suppressed ACTH after either dose. And our last category is ACTH independent. So that's when you have normal levels of ACTH, and the problem is with excess cortisol production. So it could be from corticosteroid use or having an adrenal tumor. So that's when your anterior pituitary is functioning normally, but your adrenal cortex has very high levels of cortisol being produced. So the feedback loop is actually working normally in this stage because the really high levels are suppressing the anterior pituitary. We're having very minimal ACTH input, but because there's the problem somewhere else of too much cortisol. So giving the dexamethasone will change nothing because the problem isn't with the anterior pituitary. And so the anterior pituitary is still going to be the same as before. So it's not going to be any extra suppressed. And that's why you have a low level of ACTH before, because this syndrome category doesn't rely on ACTH. We still have a high level of cortisol. And after you give dexamethasone, there's no suppression because there's no change, because there's no influence on the pituitary, extra influence, because there was nothing wrong with the pituitary in the first place. Okay, so on to Addisons. So Addisons is basically adrenal insufficiency. So it's when you don't have enough of all the hormones the adrenal glands make. So some of the key features are weight loss, skin pigmentation, vitiligo, hyperkalemia, and hyponatremia. And once again, here's a picture you can use to help you remember. Investigations, just cortisol, ACTH, aldosterone. Okay, onto hyperaldosteronism. It's also called Conn syndrome. So that's when you have lots of aldosterone, as you can tell from the name, hyper lots aldosteronism, aldosterone. And basically that messes up the RAS cycle. So it's usually caused by an adenoma in the zona glomerulosa. And so what you get is, when it messes up the RAS cycle, you get hypertension, which can lead to headaches, blurred vision, dizziness. You can get hypokalemia, which can lead to fatigue, numbness, polyuria, polydipsia, muscle cramps, and weakness. And you can also get edema. So to test for this condition, you do urine potassium and aldosterone. And treatment is either resecting the tumor or you can give the patient diuretics. And our last condition is CAH, congenital adrenal hyperplasia. This one I wouldn't worry about as much as the others because we touch on it now, but we'll go through it in more detail when we're studying repro next semester. So what it is when your adrenal cortex produces excess androgens, and you can have a decrease in aldosterone and cortisol. There's a few forms of this condition, and the main cause is 21 hydroxylase deficiency. So this enzyme here that's been crossed out in red, that's 21 hydroxylase. So if you don't have that, these aldosterone and cortisol pathways can't be completed. So all your cholesterol and all your other substances, they're diverted to this pathway to increase your androgen production. So you end up with high androgens, low aldosterone, low cortisol. This condition is autosomal recessive, so you need two parents with CAH or two parents who are carriers. In terms of clinical features, females can get ambiguous genitalia, they will reach puberty earlier, and you can have dehydration, hyponatremia, hyperkalemia, and low cortisol and aldosterone signs. And that's it for today. Thanks.